Good afternoon and welcome. I'm Dr. Sandra Hernandez. I'm President and CEO of the California Healthcare Foundation. For those of you who are not familiar with CHCF, we're an independent, not-for-profit philanthropic institution dedicated to making California's healthcare system work for all Californians, but particularly for those with low incomes and those whose needs are not well served by the status quo. Public hospitals have been in the eye of the storm since the COVID-19 epidemic began in California. Even in normal times, public hospitals play a vital role in the health of our communities. But when COVID-19 emerged, they had to perform under extraordinary conditions. In those first few days and weeks, there was limited knowledge about this virus, about how to treat it. There were shortages of protective equipment, ventilators, testing, and of course, virtually all of their flow had to be remade and redone to adapt to a COVID environment. And of course, public hospitals had to triage and treat patients with COVID while still addressing the acute healthcare needs within their communities. Meanwhile, many of the staff at public hospitals, of course, have families and children at home, and the fears for their safety and their loved ones added to what was already a very stressful situation. Public hospitals had and continue to have the added challenge of caring for those with the greatest risk of contracting COVID-19 or of dying from it. They primarily serve a low-income population, and their patients are disproportionately Black and Latino. They also play an indispensable role caring for people with the most complex health and social needs, including people experiencing homelessness, and all of these things make public hospitals all the more essential in responding to California's COVID-19 epidemic. Epidemics aren't new to public hospitals. Public hospitals have a very proud tradition of leadership and innovation and compassion in the face of public health emergencies. I spent the early part of my career at San Francisco General when it was ground zero for the HIV epidemic. Then, as now, we had to operate with limited knowledge and support and in a climate of fear to care for patients who had nowhere else to turn. Our job was not just to provide care to our patients, but also to preserve their dignity. Those working in public hospitals are still helping navigate a frightening illness, even when they may be all alone. That humanity is at the very core of those who serve in these hospitals. And it's why those who lead and work in public hospitals are so deeply driven to overcome the challenges and to improve care for their patients. And you see that in initiatives that they've launched in recent years, like Whole Person Care or the PRIME program, which allowed these public hospitals to transform the way the care is delivered in order to reduce racial and ethnic health disparities that have become so pronounced and so acute during this pandemic. With COVID-19, every day brings new challenges, and public hospitals are evolving to meet them head on. I wish I could say the work is behind us and them. Unfortunately, this virus is incredibly contagious. It is its superpower. California now finds itself dealing with a renewed surge of cases, and it makes this conversation particularly important to hear directly from our California public health leaders. I want to do a very special welcome to Tangerine Brigham and to Susan Ehrlich. The three of us worked together many moons together in the health department many years ago, and it's a great pleasure to have the two of you with us today. So with that, it's my great pleasure to turn over the program to Cara Carter, our Senior Vice President for Strategy and Program at CHCF. Cara, over to you.
Thank you, Sandra. I appreciate it. Welcome, everybody. Delighted that you could join us today, both speakers and participants. I have the great pleasure of introducing you to our speakers, but also giving you a very brief overview of the public hospitals and health systems in California and some of the role that they're playing during the COVID-19 pandemic. So start out with, who are these folks? Who are our public hospitals and health systems? So they're a vital part of our safety net. There are about 21 public healthcare systems across the state of California, and they serve just under 3 million patients annually. So while they make up only 6% of the state's hospitals, it's worth pointing out that they provide 40% of all hospital care to the uninsured in California, and about 1/3 of all care to the Medi-Cal enrollees in the communities they sit in. A few other kind of interesting facts about the hospitals. So all those visits and all of that care to the uninsured and the Medi-Cal community, as well as others, amounts to about 10 million outpatient visits each year, in addition to care in the hospital. Around a third of those patients that they see speak a primary language other than English. And when we think about things that they do in addition to seeing patients, they are primary care, or in addition to seeing patients in the hospital, they also serve as primary care providers for more than 500,000 Medi-Cal expansion enrollees, make up more than half of California's top-level trauma and burn centers, and train half of all doctors, new doctors in hospitals across the state. So even before time of pandemic, our public hospitals and health systems in California were critical to the safety net, serving Medi-Cal enrollees and the uninsured as well as others. And COVID-19 has just really brought them into the forefront of responding to the epidemic and protecting Californians. So what's been happening since? Well, we'll hear more of this from our panelists as they speak, but to give a little sense of some of the things that we see public hospitals doing, in addition to really building surge capacity and expanding testing capacity, they're of course caring for essential frontline workers with low incomes, homeless individuals across the state, others with complex medical and social needs. They're doing that building off foundations of existing programs, as well as ramping up new programs like telehealth and taking care of their own workers and workforce as they do so. So it's been a really big lift that I think we'll hear more about from our panelists, but not a lift without significant challenges going forward. So when we talk to folks like our panelists that are leading these institutions, the kinds of questions that we hear come up time and time again looking forward are things like the things here. So real questions, as I said earlier, about the workforce and its ability to sustain itself and sustain the pace at which it is working today. Questions around the increasing social needs that we're seeing in the patients. Questions around our ability to maintain ourselves financially and create stability given the surge environment that we're in. Questions around some of the things that we've seen that have helped support hospitals in this time, such as state coverage and payment policies for telehealth. Will they continue? Will they persist in the longer term? Will they become enduring? And of course, continuing to address the systemic racism and health disparities that we've seen for a long time in the context of our pandemic. So I'm really excited to introduce our panelists who are going to take this conversation to a deeper level. But before I do that, I'll just comment a few housekeeping comments. I'm not going to tell you where the fire exits are, but I am going to tell you that all our lines are muted and ask you to submit questions through the Q&A platform at the bottom center of your screen. We're recording this session, and if you are currently looking at 6 black boxes and one very small screen where you're looking at me, if you want to hide the non-video participants, all you need to do is right-click on the 3 dots at the upper right-hand side of your box and choose Hide Non-Video Participants. So with that said, let me introduce our panelists. We have 3 panelists with us today. So Tangerine Brigham, who is the Chief Administrative Officer for Population Health at Alameda Health System. We're super excited to hear from Tangerine today. She comes from a health system that serves an incredibly diverse patient population with high numbers of homeless individuals who are navigating the pandemic. We're also going to hear from Jen Cruikshank. She is the CEO at Riverside University Health System. As folks may have seen in the news over the past several weeks, Riverside has been experiencing a surge in COVID-19 patients. So among the other things that I know will benefit from hearing from Jen on, I think I'm looking forward to developing a better understanding of how they've been navigating the surge and what it has meant for their staff. And finally, I'm pleased to welcome Dr. Susan Ehrlich, the CEO of the Zuckerberg San Francisco General Hospital. Zuckerberg San Francisco has for many years been thinking about structural racism and its interplay with health and health disparities. And I know Dr. Ehrlich will share a little bit more about how this has shifted since the rise of activism in the wake of George Floyd's murder. So with that said, let me hand over to Tangerine Brigham to give us the first introduction.
Thank you so much, Cara. It's a pleasure being with all of you this afternoon. I wanted to take this time to give you an overview of Alameda Health System and to talk to you about some of the challenges we are facing, like many other healthcare delivery systems, trying to address COVID-19. Alameda Health System is in the San Francisco Bay Area, Alameda County, we are the level 1 trauma center, not only for Alameda County, but for the entire East Bay. We have a range of services from primary care to inpatient services. We operate 3 skilled nursing facilities, rehabilitation services, and we have the only locked psychiatric hospital in the county. We have a very diverse population. About 85% of our patient population are people of color. Of those individuals, about 70% to 85% are people on public insurance, be that either Medi-Cal or Medicare. We have a significant percentage of our population, a little over 45%, who have a language other than English. And so it really requires us as a delivery system to ensure that not only are we culturally competent, but that we are linguistically competent for our patient population. We see and provide over 300,000 visits for our patients in an annual year. COVID has challenged our delivery system, it's challenged our staff, and it's certainly challenged our patients. You know, it is somewhat striking that the very guidance for reducing the spread of COVID-19 from masking, absolutely, washing one's hands, but in particular, when it comes to social distancing and quarantining, are the very things that actually contribute to really challenging the health status of our low-income population. I think we all recognize that when you are low income, when you are living at the margin, community takes on much more importance in terms of your day-to-day living. And to be isolated from your community makes it very challenging to improve or, quite frankly, maintain your health status. And we in the Alameda Healthcare Delivery System recognize that. And I'd like to talk a little bit about one of the initiatives that we started as a result of COVID-19 to address this. We, like many other delivery systems, were in the unenviable position of having to severely limit access to our facilities. This meant that individuals could not have visitors, in particular, even individuals at end of life. We worked with a staff in our palliative care system with funding from foundations to create a palliative care telehealth program where we armed our nurses, our physicians, our MAs with iPads, worked to provide iPads and other equipment to our patients and their families so that they could do telehealth videos in an inpatient setting. I had the privilege of participating in a few of those sessions, and I can tell you that the incredible benefit that it brought not only to the families, but to the patients in us being able to shift quickly to provide access and to ensure that people maintained their familiar relationships and their community relationships during this difficult time. That's just one of the ways that we have done work to improve and sustain access. We have also expanded our telehealth program. We've done a lot of work for our homeless population, and I'm happy to discuss those during this webinar. So thank you very much for the opportunity, and let me turn it back over to Cara.
Thank you so much, Tangerine. Really appreciated that introduction. I'm going to hand to Jen Cruikshank now to give us an introduction from Riverside University Health System.
Good afternoon, everyone. Thank you very much for giving me the opportunity to sit here and talk with you a little bit today about what our public health systems are doing to support our communities and It is unfortunate that we have to do this today under these circumstances because we are navigating some unprecedented circumstances throughout all of these things. Our health system has been supporting many things. I could sit here all day and tell you about all of them, but I will focus on our skilled nursing facilities because they are a real integral part of our health system as we face surge. And so I'll start off just to review with you some kind of statistics. As you all have heard, Riverside County has been in the news because we are actually experiencing a surge. So I'll give you some kind of high level view. Today we have about 513 COVID positive patients in the hospital, of which 117 of them are in our ICU. That's actually double what we were looking at about a month ago. And that may not seem like a lot of patients, but we are actually continuing to serve other patients, patients that have strokes and heart attacks and traumas and that are just sick in general. And I think we are also experiencing kind of the impacts of some delayed care from our processes early in March. We have a total of 385 ICU beds in the county of Riverside, and 96% of them are full. 7 of the 17 hospitals in Riverside County are actually functioning above their licensed ICU capacity. For example, Riverside University Health System Medical Center has 36 beds, and on Monday we actually had 46 ICU patients in-house. Most of our EDs are very busy, and a lot of them are holding patients waiting for admission upstairs. Ambulance traffics are higher, and we're all just trying to figure out how to get as many patients out of the hospital as we can because they continue to come in. On March 11th, we had our first patient identified as a COVID positive patient in the skilled nursing facility. And our health system took immediate action, quick action, to quickly test all 150 residents in that facility as well as the 150 related staff. Our public health system and our public health team works closely with our hospital system, and we actually have deployed a SNF testing team. They've gone out and tested over 25 SNFs, all of the SNFs, and through that and our community drive-up testing sites, we've actually tested thousands of residents and staff relating to skilled nursing facilities. We continue to do weekly phone calls to support the skilled nursing facilities to help them understand the federal, state, and county directives, but also give them tools to be successful as they're taking care of patients from us. There are 76 skilled nursing facilities in the county of Riverside, and yesterday really only 4 of them were open for admission because they're all trying to navigate through this process at the same time as we are. Unfortunately, as you all watched, probably, on April 8th, Riverside County, with the assistance from RUHS and many other area hospitals and AMR and a lot of people in the community, had to evacuate a total of 84 patients and relocate them to other facilities. It was described to me like a parade of ambulances leaving and then arriving at many of our hospitals. Our hospital actually took 12 patients from that particular skilled nursing facility. We had a parade of patients coming in. It was an emotional and exhausting day. None of us wanted to do that. I had lots of staff calling me from that facility just in tears because it's just a lot in 8 hours to move 84 patients. We don't want to do that again, and so shortly after that, we implemented a new process. Our county emergency operations center implemented a new team called the SOS team, which is SNF plus operational support team. It is a team of a physician's assistant with a behavioral health specialist, with a paramedic and a nurse that goes out to support each of these skilled nursing facilities. And they had some goals. Their goals really were to provide education and support. They were going with PPE in hand to help teach them how to don and doff the PPE. We had to kind of fight our way into the skilled nursing facilities because they thought maybe we were the regulators and they didn't want heavy-handed regulators to come in. We wanted them to understand we were there really to support them. We created for them an easy to read and understand guide for long-term care staff as a reference that helps them keep themselves safe at work and safe when they go home, because they too were fearful for their families and what they might be bringing home. Those playbooks had frequently asked questions and support references for their behavioral health, how to use PPE, how to preserve PPE, how to perform appropriate hand hygiene, as well as how to interact with our medical health operational area coordination team, which is our MOAC team that helps to provide services and supplies in the event of an emergency. That team has been out to 558 sites since we began as of July 1st. They've been to 53 SNFs more than one time. They've been to 503 residential care facilities, and they've also gone to 13 homeless shelters, all to try to ensure that they're implementing best practices to prevent the spread of the virus. We've shared our playbook with local communities and local counties, as well as we're happy to share it out with anybody that wants it. And then recently our team has been working very closely with the nursing home that was evacuated on April 8th. Our goal is to get that place open. It's 80 to 100 beds that we could certainly use today in our care continuum across the way. They are ready. They're ready to get open, and so we really need them. And I think at that point, I will hand this back to Cara. Thank you, Cara.
Thank you so much. I really appreciate the introduction and appreciate you taking the time to be with us in this moment. Let me introduce our final panelist, Dr. Susan Ehrlich, who is going to give us what's happening on the ground from San Francisco.
Thank you, Cara. I really appreciate the opportunity to speak about our experience here at ZSFG, and especially about what it takes and what it means to lead at this time. For those of you who don't know about Zuckerberg San Francisco General, or ZSFG as I call it, we are the city's safety net hospital. We serve in typical times about 108,000 patients a year. Almost all of these folks are on Medi-Cal or Medicaid and Medicare. We're the city's only level 1 trauma center. We serve both San Francisco and northern San Mateo County, an area of about 1.5 million people. And we are the city's only psychiatric emergency service, meaning the only place where you can see a psychiatrist 24 hours a day, 7 days a week. These are, as everyone knows, unprecedented times, and we have been in perpetual surge mode since our mayor just declared a state of emergency at the end of February, before we even had any cases diagnosed in the city at all, and then issued the first shelter-in-place order on March 16th, just right after our very first case was diagnosed. It's hard to believe that this started all just about 4 months ago. It seems like a lifetime in some ways, but it hasn't been much time at all. And even in that very short time, we've evolved into a state with multiple overlapping crises. COVID, of course, a worldwide economic recession, and the increased awareness of structural racism and the need for racial justice brought on by George Floyd's terrible murder. And I think it's really important to realize that the impact of all of these crises falls squarely on the most disadvantaged in our community, especially Black and brown people and those impacted by structural racism. And I want to speak about this specifically in terms of the numbers we see here. In San Francisco, we've so far, since early March, had 4,145 people diagnosed with COVID disease and 50 deaths. In San Francisco, 50% of those diagnosed are Latinx, compared with 15% of the population here being Latinx. At our hospital, fully 80% of the 250 COVID patients we've cared for so far have been Latinx. So this is clearly a demonstration of the disproportionate impact that this disease has had on Latinx people in particular in our community. And why is this? Tangerine spoke about this a little bit. Living in close quarters with friends and family, needing to go to work every day in essential jobs, and unable to comply with shelter-in-place orders early on is what we think has led to this disparity. And it also demonstrates that our patients need more than medical care. This tripartite crisis is shining a light on their needs for sustainable income, stable food and housing, and excellent behavioral health care support, as well as, of course, medical care support. And as safety net providers, hospitals and health departments, we are uniquely poised to address these crises. This is our moment. And I just want to pause and say that I am so proud to be in San Francisco, because from the very beginning, from the end of February, our mayor, our health officer, our health department, and really our city has stood together to address this crisis, really based on science, data, and with the healthcare of the community in mind. It's been incredibly challenging to do this, balancing the public health of the community with the economic health of the community. And we are standing together to try to do this. So we have this crisis, this tripartite crisis, and it's at this moment precisely when we as organizations are under most stress. Because of COVID, every single part of our operation has changed dramatically. And I think it's important to appreciate, and maybe not well understood for those of you who don't work in hospitals, that even if we have only one patient with COVID disease in the hospital, everything we do is different. And because of the recession, of course, we're doing it with fewer resources. So just to name a few of the things that we've done and will continue to do differently in our operations. So first of all, we screen all patients, staff, and visitors as they come onto campus and into our clinical areas. And this is not a trivial thing. It's a massive 24/7 effort that on our campus requires more than 60 FTEs, 60. We cohort, organize, and provide care for our patients, for example, on the medicine wards, in the ICUs, and through telehealth in our clinics. We test staff and patients as appropriate and follow up on the results, meaning case investigation and contact tracing for staff, which is also a really significant effort. We have to surge and desurge our services so that we can provide adequate capacity for our COVID patients. We've really increased our communications so that now we have at least daily communications about what's happening throughout the campus related to COVID. And we're providing a lot of new therapies for our patients. These, of course, include dexamethasone, remdesivir, plasma, and all of these things are wonderful because they've contributed to better survival rates, most likely among our COVID patients. So all of these things in a very short period of time, and every single day presents a new challenge, new unknowns, and new issues to navigate. And this is, of course, incredibly stressful. So our employees really need far more support than ever. They need a voice, they need to be heard, they need us to support them over and over again. And we're finding that this is true for everybody, of course, but especially for our non-clinical staff, where we've seen more absenteeism, more questions. And so we spend a lot of time working with all of our staff, no matter what their background is, to really help them understand what's going on. So to get back to this question of leadership, in the past, I've written about key traits of successful leaders. These are traits that are most associated with successful organizations. And I think that these traits have never been more important. Willingness, humility, curiosity, perseverance, and self-discipline. And I would add to that the need for kindness and flexibility. So I just want to thank you for this opportunity to talk about what it's been like to be at ZSFG, and in particular, the leadership challenges we're facing. And again, I'm really proud to be here to serve our community and to stand with our remarkable team here at ZSFG. Thank you.
Thank you so much, Dr. Ehrlich. Okay, we're going to get our panel discussion, our moderated discussion started here shortly. I would remind participants on the line that if you have questions, please submit them using the Q&A function at the bottom of your screen. We will have time to take a number of questions from the audience towards the second half of the call. So while we're doing that, I thought that I would just launch into a couple of the questions that I had for you. And I'd love to pick up where Dr. Ehrlich ended, which was really talking about the new challenges and the new unknowns that staff have to navigate. I'm very conscious that Riverside, San Francisco, and Alameda have all started to see increases in COVID-19 caseload. And I'd love to just hear a little bit more about how you're thinking about surge planning and how the sustained surge planning has impacted both your workforce and your patients. And I'm happy to hand that to Jen Cruikshank to get started. Because you're
Oh.
smiling, and Riverside has certainly seen an increase.
So yes, it is. These are crazy and unprecedented times. And I think back to July 29th, or January 29th, when the first plane from Wuhan, China landed in California. And I think of our team that was there on the base, on March Air Reserve Base. They had no idea what they were walking into, but they were going. And I watched that happen every single day in all of our health systems. And I think what's happening though is we can't keep ahead of the patient volume that's coming in. So we're always trying to play catch up. And we're trying to play catch up because we're trying to learn, how do we treat these patients? We've learned a ton about how to treat and manage these patients since the beginning of this time. We're always scouring everything that we can read. And then what the staff see are just more patients coming, and it's exhausting. And so I think everybody's sort of wearing out, and we keep telling them, okay, more travelers are coming. We're competing with other states like Arizona, Texas, and Florida to try to recruit additional staff. Our physicians are tired. And just the concept of that this is going to go on for a year plus is really hard to wrap our heads around. But we continue to do it. We continue to open up space. We, as Dr. Ehrlich said, we're closing and opening or toggling the volumes of our elective surgeries and trying to bring staff in from creative places. And we're going to have to use staff in really different and creative ways.
Thank you. Tangerine, did you want to share with us how folks are holding up here in Alameda?
Well, we're barely. I think it's exhausting. I mean, I don't know if I can add more than what Susan and Jen have commented on. I think that we have not had the surge, fortunately, that unfortunately Jen has experienced in Riverside County. We have our surge plan prepared. You know, while we had an incident command center that was up and operational, we've transitioned that to trying to restore services for patients, because we know that there are a lot of patients who have delayed care, and we are concerned that we need to get them in for things that cannot be cared for via telehealth. But I think that people are really concerned with, do we have enough, tests in particular, so that if we really want to get ahead of this problem, the only way to do that is to really test. And we're not able to do that to the degree that we would like. And I think that that is a fundamental challenge, not only for our delivery system, but certainly across the nation.
Yeah. Dr. Ehrlich,
Sure. So I have so much empathy for what you're dealing with in Southern California, Jen. As Tangerine said, fortunately, we're not in that place right now. We are deeply concerned, though, because right now we're sitting at a 20% week over week increase in hospitalized patients in San Francisco. That's really the leading indicator that we're looking at right now to see, and try to predict what's coming down the road. Fortunately, we still do have plenty of capacity, both in med-surg and ICU beds. And we've spent a lot of time, even back from February, as a group of hospitals in San Francisco to jointly plan for that, sad day when we might have, the kind of capacity constraints that you have down in Riverside. So we know exactly how many med-surg beds we have available in the city. We know exactly how many ICU beds. We've also looked at our surge capacity. So if we needed to go beyond our current capacity, how many beds do we have in the PACUs that we could convert to ICUs? How many ORs could we convert to ICUs? How many other spaces? And then the city has gone even beyond that. I just was visiting our low acuity care site, which is basically a warehouse where we would take people who weren't COVID positive, but a place where we could decompress hospitals should we need to. So we're doing a lot of planning, and even with few patients, we have 15 patients today in our hospital who are COVID positive or awaiting test results. It's still exhausting. It's still exhausting.
Thank you. I appreciate that. I'd love to just, I mean, we're talking about the impact on the workforce and providers, and I wanted to talk a little bit about the impact on the patients as well. So one thing that caught my ear that Tangerine mentioned was the, amplifying the experience of isolation for the patients that you serve in this time. And I would love to know, I'd love to hear a little bit more what experience you're hearing from patients and what needs they're turning up with that may be different in this moment.
We have a complex care management program and a care transitions program. And those programs are comprised of social workers and community outreach workers who actually go into the homes of our patients. We had to certainly develop protocols for those patients as a result of COVID, because in some instances, people were not comfortable for us coming into their homes, so we've tried to do it telephonically and through video. And I will tell you that we've done more assistance around social needs, helping many more people around food security, helping many more people in terms of ensuring that they have their IHSS in place. And so I think there's all of those types of things, and quite frankly, just being a lending ear to our patients. I think that they have really valued the fact that we've been able to do telemedicine. One of our providers, I remember saying that, in fact, she finds herself spending more time doing telephonic visits than she did inpatient visits, in part because people have someone who they can talk to. They don't want to sort of let them off the phone. And so we're seeing that a lot in our patient population.
Thank you. Dr. Ehrlich or Jennifer, anything you'd add?
Yeah, we're seeing the same thing. I'm a primary care physician, and I'm seeing most of my patients now, seeing them over the phone. We're doing about 40% of our visits now in primary care, either over the phone or through video. It's been a great thing to be able to reach out to people. And what I can say is that, our patients need so much more than healthcare. First of all, they're really stressed out. So even if they need to come in for healthcare, oftentimes they don't want to because they're afraid to go out. They're afraid to come into the hospital. So we need to convince them when they need to come in sometimes. They need food. They need stable housing. They need an income. All of these things are things that we as a city, as a hospital, and also as a city are helping people with. Our city has spent a lot of time and effort and money buying hotel rooms, both places, hundreds of them, where people can shelter in place and where people can quarantine if they are diagnosed with COVID disease and they don't have a safe or secure place to be. So our patients' needs are tremendous at this time, and our community's needs are tremendous. And I'm just really glad that we can do as much as we do to try to support them.
The only thing that I'll add to that conversation, because we share a lot of the same approaches, is that we do encounter some challenges trying to find hotels and cities that will allow us to house people that have COVID positive diagnoses or are in quarantine or are homeless or have any sort of behavioral health or mental illness, which is a challenge. And then within the last few weeks, I did get a phone call from our Department of Behavioral Health, and we've done a lot of telehealth work with our psychiatric and behavioral health services, and he acknowledged that we needed to do more face-to-face care because we are actually experiencing and observing increase in suicide attempts and increase in substance abuse. And so we're actually having to be really very purposeful on reaching out and to serve that portion of the population too.
Thank you. I mean, on to follow that thread for a little bit, the needs of people experiencing homelessness in this moment feel very acute. So Dr. Ehrlich talked about the tripartite crises of our time, which I fully agree with. And I just note that they are layered on top of, the crises that we had before that, of which homelessness was at the forefront in our state. Would each of you be able to say something about how you're working with the city or county offices to think about meeting the unique needs of the homeless population?
Sure. So Alameda Health System for many years has purchased post-acute care options for our homeless patients. They could be board and care, it could be motels, respite for the population. And we have always partnered with Alameda County's Healthcare Services Agency for that effort. They have been done a Herculean job during this pandemic. So some of the things that we've partnered with them on specifically, they have been able to bring up 2 hotels for homeless individuals. And we've been able to refer individuals who are homeless after they have essentially what's called ruled out. They're no longer, we've gotten their test results, and we've been able to place them into quarantine settings for them to do the remaining other 14 days. And so that has been really helpful. And more importantly, it has provided an opportunity for the county to really work with those individuals to identify permanent options post living in any of the COVID hotels. Because what we don't want to happen in our community is for them to go from the hospital into a COVID hotel and then back onto the street. That just continues the vicious cycle that we have all heard about and known about. And so that partnership has been critical, and certainly we anticipate it will continue and be strengthened, and we've learned a lot around how to approach our homeless populations and how to partner more effectively as a result of the times that we're in.
Thank you. Jennifer, is there anything you'd like to share on? Nope. Okay, all good. Dr. Ehrlich, anything else you'd share on homelessness?
It's obviously a huge issue in our city even before COVID. And the city, as I mentioned, has really stepped up to rent these shelter-in-place hotel rooms as well as the isolation and quarantine rooms. And it sounds like an easy thing to rent hotel rooms in a city that now has a vacancy rate that is, I don't know what it is, maybe 90% now. But they need to be staffed. There needs to be an organization that refers people there and make sure they have what they need there. So it's a huge effort. And it's not just the health department that's involved in this. It's actually mostly the Human Services Agency, the Homelessness Agency, all agencies of the city coming together to address this. And I also want to mention that there's a lot of philanthropic support for this effort. So it is truly the public and the private parts of the city coming together to do the best they can in this really challenging time.
Thank you. I'm going to turn to the audience questions in just a minute, but the last thing on my mind, in your introductions, you've all focused on the patients in the workforce, and none of you have mentioned the financial constraints that the health systems themselves might be facing in this moment. And yet I know them to be acute. And so I was wondering if you could comment a little bit on your thoughts there, as well as anything that's been helpful in this time.
Well, I can start. I think, there's just a lot of unknowns right now because we know that the city has projected, San Francisco City and County has projected a $1.7 billion deficit over the next 2 years. This is at a time when we need even more resources to respond to this crisis we have with COVID disease. The city is restarting its budget process. We started it as we typically do in January, February. It was put on pause. Now it's restarted again. So we're not quite sure how it's all going to shake out. We know that the city, like the state, is using reserves to try to cushion the blow at this time and in the first year. We also really don't know how much state and federal reimbursement is going to help. So, There are federal grants that have come in that have covered part of our costs. We know FEMA is going to be a source of funding for some of our costs, but I have to say it's just really unknown at this time. And you know, we'll find out more as the summer and the fall goes on.
Yeah, let me just add, I'm sure most of the participants on the webinar realize this, but you know, as a healthcare delivery system, our funding is tied to visits, right? And when we have not been able to have be it either face-to-face primary care visits, we've canceled specialty visits, we've canceled non-emergent outpatient surgeries, inpatient surgeries. That is what impacts our financials, not being able to actually do the work that, you know, we as healthcare delivery systems are trained to do, have the expertise to do. I don't see that changing for a while. I think we're going to be in the situation in which we continue to have expenses for our delivery system, and we don't have the revenue to cover those expenses. And the expenses have increased by virtue of the fact that we, as Susan was alluding to before, and certainly Jennifer, PPE expenses that we previously did not have in the past. We've had to, because we've had some of our staff who have taken leaves for family-related issues, we've had to backfill with staff that generally is more expensive, as Jen was alluding to, because we're competing with other delivery systems, trying to get those nurses, those MAs, those clerks on board. And that's not going to, as I say, change. And so we're going to be in this very difficult situation of being unknown and unclear really what the level of federal support will be in the future to weather the storm.
Thank you.
I'll just cap that off with, here we've spent so many years trying to reduce the cost of care in our health systems, and really everything we're doing is antithetical to that. So we're adding testing on top of testing and PPE and different levels of people and spending more money and access. And it's not because we're being irresponsible, we're trying to do the right thing, but it's everything that we've been trying to do to improve access to care has been sort of wiped away in a half a second.
Wow, that is certainly true and certainly sobering. I'm going to turn to some questions from the audience now. I have a number of questions from participants. The first that I'd love to pick up is a number of you have mentioned, and we've all seen the disproportionate impact on Black and Latinx communities from COVID-19. The question was, are there any recommendations or anything that you can share from your experience of the changes that you've made to better serve these communities?
Well, I can just say, one of the things, there's been a lot of things we've done in San Francisco, in particular focused on the Latinx community and the Mission neighborhood where we ZSFG, and there's a large percentage of Latinx people there. So first, UCSF did a prevalence study of disease in the Latinx community, which helped us really understand what the basic rate of infection is there, as well as the risk factors for infection. For example, people going to work were more likely to be COVID positive than those who weren't. And there's a huge amount of outreach that we're doing in that community, meaning that the health department and the city, about keeping yourself protected, offering more testing, doing contact tracing, providing face coverings. So lots and lots of outreach, information and education to the community, as well as providing the shelter-in-place hotel rooms and the isolation and quarantine rooms to people who require that.
Thank you. Jen, Tangerine?
Yeah.
Go ahead.
So in Alameda, some similar activities to what Susan described in San Francisco, a significant sort of outreach within our community. In Alameda County, more than half of the cases have been Latinx. About 8% or so have been people of African American descent. So we have partnered with our public health department. We're not part of the health department, but we've partnered with them on education. The other thing we've done, we have a pretty diverse group of staff who are our community health outreach workers. We try to hire from the community to the fullest extent possible. And those individuals have really been ambassadors for us to those hard to reach communities. We're doing a lot of work specifically in the Mom community. Those are individuals who are indigenous of Guatemala, specifically because we know that for a variety of reasons, isolation, language, that we need to do more in that area. And so that has been a focus of ours.
Thank you. Jen?
Yeah. Well, and really that Tangerine hit that right on the head. That's exactly what we're trying to do. We have to stop responding to the COVID positive results, and we have to figure out how do we connect with and engage the community with trusted leaders of whatever the isolated group is, and try to help them be proactive with their own communities so that it's not big government coming down and saying, here's what you need to do.
Got it. I have another interesting question here about the mental health needs of your workforce. Both what's happening now, how we're currently supporting them, and what the future of addressing the mental health needs of the healthcare workforce might look like.
Well, I'll start, and then I'll let the two brilliant women to my right and left finish it off and hit the home run. But so one, I worry a lot about the healthcare workers because healthcare workers typically don't take care of themselves. They usually are stoic individuals that can survive and they'll get through it. In our county, our behavioral health team has a crisis hotline for healthcare workers. And when we started this in March, we were getting about 47 or 45 calls a week, and that has grown. But it takes a toll, and I'm a nurse, so I think I can say this. We just dig in and do, and then it's almost too late when you look up. And so we have to be really, really diligent around giving them tools, and as employers, just making them stop and having different ways to fill their bucket and stay healthy and not just focus on this. And one of the funniest things that I hear regularly from our behavioral health team is we have to tell our team to stop reading social media because it just wears them down.
Good advice.
Yeah, I couldn't agree with Jen more. I think the mental health needs of our workforce are, they're huge. And a lot of it is because, the people who come here are just so incredibly courageous and just want to help and do as more and more and more than anybody, most people would be willing to even start to do. And so that just leads to a lot of stress over time. The constantly changing conditions, just that in and of itself is really stressful. And then when you add to it all that's going on around visibility around structural racism and disparities, I think that just adds a whole other level. Many of our staff, are repeatedly traumatized by these discussions and what's happening in the communities. So there's just many, many things. Then you add in the economic conditions. There are many things that add to the stress that our workforce is experiencing. We try different things to, we make sure that, standard EAP, but we also have our Department of Psychiatry here that has developed some programs specifically for staff, UCSF staff, as well as Department of Public Health. I think we're going to need to do more. And we'll just, like everything else we're doing right now, we're going to have to, build the plane while we're flying it. But it is, I think it's really a huge need.
Yeah, I will just say that in Alameda Health System, we recognize the same thing that Jen and Susan have talked about. We are grateful that our chaplains have extended themselves to our staff, and so that has been really a great opportunity. We actually have a wellness coordinator, I'm sure I'm butchering her title, for the organization, and every week she sends out emails on sort of group activities that are being done via the Zoom for our staff in terms of trying to help them. We do have a psychiatrist on board for our physicians and staff, and then we did go through the effort of expanding our behavioral health services benefits and really just broader family supports, for our staff, from it, the babysitter for the dog. I don't have a dog, so I don't know what they call the babysitter for the dog, but we offer that. What is that called?
Dog sitter.
Dog sitter. That's the one. We've got all of those kinds of things to help people. But I think, as Jen was indicating, it's very difficult for people in the healthcare delivery system to ask for help. And I think that is really what I'm concerned about, and I know our executive team and senior leadership is concerned about, because we don't want people suffering in silence. We don't want that.
Thank you. So speaking of asking for help, I've been given the 2-minute warning, but I would love to do a lightning round about what help you need and what you would love our audience participants or listeners to know about what you think you need most in the coming months to effectively serve you.
Well, let me just say, I'll say maybe 3 things. There's been flexibility that's been offered to healthcare delivery systems during this unprecedented time, particularly when it comes to telehealth and funding for telehealth and funding for televisits. That needs to stay in place. I think that is critical to help try to sustain our delivery system. That would be the first thing. The second thing is, we need to ensure that there's adequate access to the tests, the reagents, so that we're able to test asymptomatic patients and our employees on a regular basis. I think that is critical, I think, and this is probably pie in the sky, consistent messaging from our federal government on the importance of what it means to be in the midst of a communicable disease, and what we need to ensure that we all get out of this, hopefully no more scathed than we are today.
Yeah, I would just like to underscore what Tangerine said first about the regulatory flexibility. That is huge. So it's definitely the funding for the telehealth visits, but it's also just regulatory flexibility in our hospital. So being able to, overnight turn an ICU unit into med-surg or back, all of that, or skilled nursing, all of that is incredibly important right now. And it seems, very bureaucratic, but it's huge. The second thing I would say is just the basics, right? We need staff, we need PPE, we need equipment, we need tests and reagents, just enough of all of that stuff, and plenty when we, enter a surge period. And then the third thing I would say is that the people who really need the help and support are our patients. And it's the basics. They need stable income, stable housing, stable food sources, and stable health and behavioral health care.
Thank you. Jen.
I can't add anything new because the 2 of these women have done such a beautiful job, but I will just say, be ambassadors to good, safe living out in society so that we're not overwhelming our health system. Stay at home if you can. Wear your masks or cover your face and stay 6 feet apart, and avoid those backyard gatherings, and just be safe so we're stopping the spread.
Thank you. Okay, we're gonna wrap up because we're at time. I wanna just thank all 3 of you for your time today. I found it incredibly helpful Really terrific to learn more about what you're doing, and really grateful to you all for making the time to sit with us when things are so busy back where you're at. So just really wanted to extend our gratitude to you. And for folks on the phone, I wanted to just invite you to fill out the feedback survey that you can see in Zoom. It really helps us learn to do these briefings better and make sure that folks' needs.